this week on the BackTable podcast.
I think the point is not whether or not you do it single port or fan and steel, mini lap, whatever, is that as gynecologists, who are doing so many things in the world, right? Babies, HRT, hysterectomies, everything, vaginal surgery, laparoscopic surgery, prolapse, right? The true generalist who's doing it all is just to think outside the box, and you have to know your anatomy enough that you can approach things from a different way. That's what I mean, right? So you can do a fan and steel and still keep it minimally invasive, right? Obviously not open things up.
And welcome back to another episode of BackTable OBGYN. I'm your host, Mark Hoffman, and I've got with me once again, Dr. Amy Park. Amy, how are you?
Great. How are you doing?
I'm good. Thanks for joining us. It's always more fun when you're here. And we have another great guest, friend of both of ours, coming from Charlotte, North Carolina, Dr. Kevin Stepp. Kevin, how's it going, man?
It's going great. Thanks so much for having me on. I've been looking forward to this.
It's a pleasure to have you. Dr. Kevin Stepp is a MIGS surgeon and urogynecologist, completed both fellowships, right? Yeah. You're currently at Advanced Pelvic Surgery and Urogynecology of Charlotte. You're a professor of OBGYN at Wake Forest School of Medicine in Charlotte and the clinical director for Urogynecology and MIGS at UrCAD USA, which is new, right? Opening up soon, you said?
Yeah, it's brand new. It's been a project of ours at the university and in Charlotte for a couple of years. Took a lot to get it to come to fruition. It's the first one in North America.
It's awesome. And we'll talk about that a little bit more later. But like we like to do with all of our guests, we like our listeners to get to know you a little bit and tell us a little bit about how you got to be where you are and doing what you're doing.
Probably like a lot of your guests, serendipity. Grew up in Detroit, went to college at Michigan State University, med school at Wayne State in Detroit, and then as luck would have it, I matched in Cleveland for residency. Ended up sticking around and doing fellowships at Cleveland Clinic. Back at the time when urogynecology was not board certified, but it was one of the first board accredited fellowships. Got lucky, met some great people, a lot of people obviously that we know, and got to focus on two different things. So me and one of my colleagues were the last people to come through to actually get a certificate in minimally invasive gynecologic surgery and urogynecology. And as far as I know, I think I'm one of the only people who actually still maintains that practice. And that has been a blessing throughout my career. So stayed in Cleveland for another total of 12 years and then moved down to Charlotte about 15 years ago. Recently just sort of changed my focus, delving into some new and exciting things, for maybe the latter stage of my career.
It's exciting. No, it's always interesting to hear how people got to be where they are, and it's never quite as linear as we think it's going to be. So are you from Detroit, the city, or a suburb?
So actually I've lived all around, depends on who I'm talking to. So I grew up in the suburb, but I also lived downtown growing up a little bit, like that house doesn't exist anymore kind of place. First one to ever go to college in the family. And then moved to Cleveland and here we are.
Well, go blue, but we have our Sparty friends as well that we tolerate. But so we wanted to have you come on today and chat with us about single port laparoscopy. So those of us who didn't work with you directly, or at least those of us who have been to AGL or other meetings have sort of seen when that was sort of starting out, you were like the guy doing that for a lot of it. So talk to us a little bit about how you got involved in that.
So again, just a really serendipitous thing. I was literally walking down the hallway of the county hospital and I saw this guy named Corky. He was a rep at the time. And he had this instrument that was curved. And I said, well, what's that? I said, oh, we do this for lap Nissens and things. And I was like, well, that's interesting. And right at that time, this was in 2007, end of 2007, early 2008. And there was a conference, people were talking about this single port laparoscopy. I said, well, I wonder if I could do that. So we started talking back and forth. I quite literally got online and there were two companies that made ports. One was Triport, which is now sold and marketed by Olympus. And the other was another one called P-Naval. I emailed them both like on the investors page. The one guy said from Triport, he said, yeah, well, I can ship one over to Cleveland. So pretty much I did some work on a trainer at home, like I always encourage all of our trainees to do. And then had a great patient, dental hygienist. I remember her vividly. She was excited, needed to get back to work. We did her case. It was publicized. We had the news there, and the rest really just sort of took off.
The first case you did, you had the news there?
Yeah. Yeah.
Glad it went well.
What was it? Was it a hyst or what was it?
Yeah, it was a hysterectomy. Yeah. It was a appropriately chosen patient. I mean, it was not a very difficult hysterectomy. And again, there's a lot of time from deciding that she might be a candidate to actually doing it, right? So that was back in the day when the companies would give you a trainer and we would just take it home, and it was sitting on my kitchen table. I was young, newly married, and this is what I would do in the evenings. And so we had a pretty good game plan going into it. And obviously this is the thing about single port, especially back then, you could always just add a port, right? And so it wasn't like something crazy. It was just, you're going to start with one port, and if you needed to, you could add another. If you needed another, you add another, and now you're back to what you've always done.
So you hadn't done like a salpingectomy or anything. It was just like, we're going to go straight in with this case.
Yeah. Yeah.
I mean, I think about like, and we've heard all the talks from all the pioneers and all the folks that do that, but to think about the guts, number one, it takes to do it. I mean, and it's never just like, I'm going to try it. Like, obviously you put in hours and hours of work and you're already an accomplished surgeon at that point. The anatomy doesn't change. And so I don't want anyone to think for a second you're just like seeing how this works. But that first one is a pretty tall step, right?
Yeah.
And it's a pretty bold thing. And this is a Cleveland clinic, or this is at?
So this is at Metro Health. This is the county hospital across the street.
Okay.
But again, I felt it was, and I had talked with the patient, and we just add a port. If we needed to, we could add a port. And even to this day, that's part of my counseling, right? If I'm going to do a single port, surgery, I could always just add a port. And hopefully we'll get into that. And pretty soon, pretty quickly, it just becomes your routine case. And, I guess I should, let me back up and explain a little bit. So this was also the time when we had 10 millimeter instruments, right? And so the natural progression of my cases was 4 ports, but I didn't like putting the 10 millimeter ports down low and lateral, those lower ports, because those were painful, right? You had to close them, the stitches, you would get a nerve. So I didn't like doing that. So I had gone from 4 ports to 3 ports on my own before this single port stuff happened. We only had 10 millimeter energy at the time. And so then I had transitioned to using a 5 camera and having my 10 millimeter energy coming in through the umbilicus. So it's already coming down. So really the big change for me wasn't how am I going to do the hysterectomy, but where am I going to put my camera?
Well, that's
and I just had to work out where my hands go. And so it wasn't like I was like, oh, let's just try something completely new. I was already having my energy come down vertical from the midline. And I think there's some real advantages to that. And so that's, I suppose, maybe makes it sound a little bit more like a natural progression. Just went from 4 ports to 3 ports to 2 ports to 1 port.
And there was probably no surgery. Had anyone done a single port hysterectomy to your knowledge by that point, or?
So the very, very first one was actually done by a general surgeon in Texas who went across the border to Mexico, and his brother was a gynecologist, and they did one. There was a doc whose husband, she was a oncologist, and her husband was really one of the real pioneers and might have done the first single port ever in any specialty. And so she had done one. And so I think I was a third in the world to do a single port. But fast forward 3 or 4 or 5 years, and I'm talking to the guy who sent over that first port. And he mentions like that was the first time a purpose-built port had ever been used for single port laparoscopy. His was the first on the market. And that was the first time. I didn't even know that. So that was
that's pretty amazing.
Yeah.
So, I mean, thinking about like all of sort of the innovations over the years as that's come along, And having done a handful of those cases, it's not something I've made part of my practice. It does feel like the learning curve can be pretty steep for those. And I guess why do you think that is? What do you think are the most challenging things about doing things through one port?
Well, it's not easier to learn or anything like that. It does have a steep learning curve. I think it worked for me because I've always been a sort of a forward thinker, techie, kind of wanted to be I'm an early adopter, not somebody who's going to be the last one. There are other folks that I need all the data, and one is not worse than the other. One is not better than the other. But I tended to be an early adopter. So I was experienced enough that I had the hands and I had a high volume practice to learn. But I also was young enough and humble enough to understand that I have to do things differently. I've taught hundreds of people how to do this. And back in the day in 08, 09, 10, we had a lot of the really popular people that we know who are elite surgeons. And it doesn't surprise me that it's not something that a lot of really good surgeons pick up, because you're used to walking up to the table, you're using two hands, you're able to do what you want to do, you don't have to think about it. To do this, you really sort of have to think about it. And my mindset at the time was innovation and fewer and smaller incisions. Whether I went from 4 to 2 or 4 to 1, I wanted fewer and smaller incisions. And I was young enough that I was able to, dedicate that time to it.
What do you think the key advantages are to single port? I mean, you are talking about less incisions. Does that mean less pain, cosmesis?
I wish there was a lot of people who thought about, who tried to study and prove that it was less pain. I honestly don't know if it's less pain, right? I think it's less pain if you're using anything bigger than a 5 millimeter port. I do robotics as well. It's less pain than robotics on the abdominal wall. But, tab blocks have helped a ton. So I don't think pain is the major driver here. I think if you've ever had an inferior epigastric or a muscle hematoma, those are 0% with a single port. And now for a hysterectomy, once you get through your learning curve, it's pretty darn easy to feel confident you're going to be able to get this done without a whole lot of extra time, if any. My times are just about the same. Now, my patient selection is probably different, right? I'm doing harder cases without single port, but my time is about the same. So I think it's cosmesis. I think it's just fewer and smaller. If you don't need to put 5 incisions, put 4. If you don't need to put 3, put 2. So for me, just to clarify and throw it out there, a hysterectomy in general for fibroids is single port almost all the time. However, and it doesn't matter really size of the fibroids or anything like that. However, endometriosis is not a great case for single port. That being said, I might start single port and add a port and then add another. So even in a sort of a worst case scenario, I've got my umbilical port, which I can put 2 or 3 instruments through. And I've got 1 or 2 down at my, right and left lower quadrants. And I don't have any visible scars, right? I don't have any upper quadrant scars. I don't have any left upper quadrant scars, but I still get 4 hands.
How about the umbilical hernia risk?
I think it probably exists with the port that I'm using most of the time. My incision is 14 millimeters. That's the incision on the fascia. And I know that because that's how big the introducer is. So I don't think I'm getting much increased risk there. That being said, the majority of these cases that I'm really doing single port on are hysterectomies now. I've done just about everything that we do through single port, but the ones that I really focus on now is hysterectomy. So if you're doing a hysterectomy now, you have to get the specimen out somewhere. I think the least traumatic way to do that is to put it in a bag and bring it out through the umbilicus, which means that now I actually have to enlarge my single port incision to get the uterus out.
You don't deliver it vaginally.
I don't.
No.
I think it, well, these don't fit almost always for what I'm talking about. And I think it's more traumatic.
Interesting.
Talk about that. Because I am someone who tries to do as many as I can. I use 5mm incisions for everything. If I ever have to do anything bigger, I try to, keep it midline, like you said. But if I can morcellate from below, I almost always try to. And I feel like, especially now with the in-bag morcellator or tissue extraction bag, they have the Lexus retractor they put in, kind of holds pressure on the cuff for a little while.
I just think that patients, I'm not a woman, so I really can't say, but there's a lot of pulling that happens, right? Whereas when I'm doing a TLH, a completely TLH with however many ports, there's no pulling on the vagina. Maybe because of my focus on umbilical incisions over the years, I can make that cosmetic. So I think that from that standpoint, now, if you're doing 5mm ports and you got a 5 at the umbilicus and then you extract it vaginally, you're going to have a lower hernia rate for sure than even if I just put a 10 in. So from that standpoint, I can't be critical of that.
No, I mean, it's thinking about cosmetically, yes, it's definitely, you're going to get some 5mm incisions, but I think I've heard anywhere from 15 to 33% hernia rate, depending on the size, for the morcellation, 3cm umbilical incisions. And this is a couple of different things I've read, but I've seen it can be pretty high. So talk about how you make those umbilical incisions and how you close them.
So, well, first of all, if I'm making a 3cm umbilical incision, that's a 1,500 gram uterus. That's a big uterus. So in which case, then I definitely would rather do that than go down below and try to morcellate that. I think that is just more trauma. This is just my opinion, right? I mean, Roseanne Coe, you guys, there's plenty of way. And it also depends, is this a urogyn patient? Is this somebody who's got some prolapse, or a Paris patient, or is this, G1 with major fibroids who's only had who had a C-section and never had anything vaginal? So
I think that's an important point. That exam, when you first either meet the patient or in the OR, you're like, okay, this is going to be an umbilical extraction because there's just no room down there, right?
Yeah, when you go to put the manipulator in and you can barely fit the manipulator, it's
not coming out from below.
Right. So what do I do? So if I've got a big uterus like that, we're talking about hernia risk anyway. So, and then I close it. I use delayed absorbable. If there's any hint of a weakness there, sometimes you find, I've got an hour-long lecture on the anatomy of the umbilicus, literally. There's, I think, 6 different types of anatomy of the umbilicus and the umbilical ring. And so how I'm closing, when I'm going in and I see a weakness there, or maybe an occult hernia or a small hernia, I'm going to close that with something more aggressive, right? Like PDS for sure, maybe even more than that. I run it. It's more than a figure of 8. It's a good full thickness closure to get that to close. And then there's different ways, again, it goes back to that lecture. Around that same time, just my son had a hernia. He was a young boy. He had a hernia. And so I was talking with the pediatric surgeon at university hospitals. And then we started talking, and then I actually operated with him on a different case. And he showed me this thing called the umbilical omega incision, which is, if you think about people with, babies with pyloric stenosis, or they're doing these things on young kids. And so they make this omega incision. Think of the Greek omega. And that's a way to make an incision that is about 70% longer with no scar, and it doesn't distort the umbilicus. So you can hide that incision and make it very cosmetic.
So how do you make is that what you do?
Most of the time I'm doing, because again, back then our incisions were a little bigger. Now I'm using 14mm, 15mm incisions, unless I have to morcellate. So most of the time it's a vertical incision, if I'm honest. But sometimes you do have, if someone comes to me and they want a single port and they have just one of those little tiny belly buttons, right? You're not going to get, you're going to be able to see it if you do a 2cm, 3cm skin incision. So you can do an omega incision there and have it be more cosmetic, if that's something that we're doing.
Are you sort of cutting off the stalk of the belly button in that omega? Or are you going, because I think that's something that is where, I don't do Hassan routinely. But I think about grab the umbilicus and try to get in that way. Like if you sort of like decapitate the umbilicus and have to kind of resew it back on. Like talk about how where you make that incision.
The omega incision does sort of, and I have this lecture, and you create, it's an omega, but it's in 3 dimensions, right? So think of a bowl, right? And so it's across the surface of the abdomen, down the side walls, and then across the bottom. So that's your omega. And then when you close it, it's almost like a flap, and you kind of rotate that little thing there, so it actually becomes more of a U when you close it. But while you're doing it, it's actually like a toilet seat. You do separate it from the stalk. And then you can make your incision on the fascia vertical. So the incision on the fascia is the same. It's just a midline incision. Then you do your work and you bring that down. It's more intensive. It's not for every patient. Definitely takes some practice to make that good. I'm learning. So I share an office with a plastic surgeon right now. And so there are women which will come and just say, can you make my belly button look younger? I mean, so that's a whole nother podcast. But there's a lot of people who care about the way their belly button looks like. Patient asked me this morning, what's my belly button going to look like? We're going into the operating room. What's my belly button going to look like when I wake up?
People care about their belly buttons.
They do.
They do. And it's a study, I think, folks who've had them taken out for other surgical regions, like it really bothers them to not have a belly button, like a one they like. What are the biggest challenges? So like once you're in, I think getting in is sort of something that for most of us know how to get in, but again, different, whether it's just some folks go right across the umbilicus versus the omega. Once you're in, you said you have an introducer. What kind of port do you use? Because most of the ports that I think of, like gel port and those things, are bigger than that. There's a smaller port that's just for single port laparoscopy.
So there's 2 ports that I use routinely, and I've used just about all of them I was giving courses, and it was much more popular at one point, much more intriguing, I should say. And so I've used almost all of them, but the 2 that I've sort of settled on there's an Olympus one, which comes in either a triport or a quad port, which is the blue one. That's going to give me a smaller hole. So if I have a thinner patient, smaller uterus, I know I'm not going to have to, morcellate a 2,000 gram uterus, then I like that one. That's also a good one for my endometriosis patients, because that's the same size incision as if you do a Hassan. It literally is the same. So you put that in, and now I have a 5 millimeter flexible camera. That's key. We'll talk about that. So I use the Olympus port for that, which is the one I've been using since 2008. And then I have the Applied Gel Point Mini, which requires a 2 centimeter incision. And so that one is for if I've got just a big uterus or a big patient where the abdominal wall is very thick and you need a larger ring so that it doesn't pop out. You don't lose pneumo.
That's the one I've seen and used. And I'll use those. Really, the main reason I use it is if I'm going to morcellate. For a long time, I would do my 4/5s, and then I would do the whole case. And then I would make a mini laparotomy to morcellate. And at one point, I'm like, why would I not just do that from the start of the case? I mostly do mine through a fan steel, like a mini lap fan steel. That's how I trained. I did so many abdominal cerclages with Arthur Haney at University of Chicago. And mostly he just let us get in and get out. But we could do the entire case through, 1.5, 2 centimeter incisions. And then with Frank II and Sangeeta in Chicago, we were doing myomectomies to these small incisions. And then at Michigan, it was just like wherever I was at that time, there was always someone there doing stuff through a mini lap. And I became really sort of like enthralled with the mini lap fan steel incision. And I use that a lot now for morcellation. I use that for, if I know I'm going to, I'll put that in first. In my robot cases too, sometimes I'll do that as our assist and then, come back and do it. So that's the one I've used. But
I love that. I love that a lot. So I kind of went the same thing for myomectomies, right? I've done single port myomectomies, but it's a lot of work for minimal gain, and then you have to extract. So what I started doing is everything is just think critically, like you just did, right? So do a mini lap in the umbilicus. Well, it's actually more cosmetic if you put it down below. So I started doing mini lap myomectomy. I started doing my extraction through the umbilicus, through the fan and steel mini lap like you described. But then I was like, well, wait, why don't I just put that in first and see how many fibroids I can get out. So now on 90% of my myomectomies, again, no matter how big they are, I do it all through that little mini, like literally 4 centimeters.
Single port through a fan steel.
Not laparoscopic.
Oh, yeah, I know. Yeah, I will do, unless it's truly posterior pathology, I can get the vast majority of the fibroids out through 3 to 4 centimeter mini lap, because the uterus comes to you. Unlike a hysterectomy, you got to go get down into the pelvis. The uterus moves around. And also they're getting a C-section. So I've talked to my friends for years and years. I'm going, so wait a second, you're doing all this stuff, you're morcellating and making a big umbilical incision. How are they having that kid? I go, well, C-section. Well, so just start with that. Do the mini lap fan steel. You can always add an umbilical port. You can always, like you said, same idea, but starting with that incision, it gives you so many options, but they're gonna get a C-section. We've committed them to that with this surgery. Use it. And that was something they were like, okay, that's a good point.
And then you have no scar, right? Then your scar goes away.
It's hidden.
Gone.
So, and that's how I've started doing my tubules, 2-port tubules. So I put a 5 through the belly button and then a 5 suprapubic. I put bring the uterus way up high, and then I'll just sort of get the cornua with the smart bipolar. But then when you get down real low, it kind of pushes down in the bowel or in the sidewall. So I put a endo loop on the cornua, pull it out, and then it pulls the tube up. And so then I can, through the same port, I'm pulling the fishing line up with the fallopian tube cornua, lifts it up, and you come down the mesosalpinx, and it lifts it up right into your instrument, like in a straight line. Pull your instrument out, and like a fishing line, it pulls the tube right out.
Man, that's great.
It's like, I had no resident, no student. I was in my tech, and I was like, I'm just going to do this myself. And it was like the easiest thing. It was one hand on the camera, one hand on the instrument. It was like, and then my tech turned to me and goes, that was slick as snot. It was literally like a straight line. And so it was super cool. And there's, again, you can't see any incisions.
So I think that one of the things, right, as I was thinking about, okay, what are we going to talk about? I think the point is not whether or not you do it single port or fan and steel, mini lap, whatever, is that as gynecologists, who are doing so many things in the world, right? Babies, HRT, hysterectomies, everything, vaginal surgery, laparoscopic surgery, prolapse, right? The true generalist who's doing it all is just to think outside the box, and you have to know your anatomy enough that you can approach things from a different way. So that's what I mean, right? So you can do a fan and steel and still keep it minimally invasive, right? Obviously not open things up. But I was at a conference where there was, as a urogyn, right? I like to hang out with urologists also. And so I'll do, like when endo is on today, took out 5 centimeter mass endo on the bladder, right? That uses both my skills, urogyn and MIGS. And when I hang out with the prostate surgeons, they have at least 3 different ways to do a prostatectomy. Whereas for the most part, even if we're doing robotic, laparoscopic, they're all intraperitoneal hysterectomies, except for vaginal, right? Obviously, vaginal is very different. So if you can come in from a fan and steel and think about attacking, you have to know your anatomy well enough that you can attack it from different directions. And I learned that from single port, because single port, I'm using articulating camera. So I'm seeing it from over here, from over here, from over there. And so looking at it from a different perspective, knowing your anatomy, sometimes you go up, sometimes you go down, sometimes you come from the right, from the left. So I think that, as the march of science happens, we're going to learn different ways to do things. Whether or not it's single port or robotics, or hopefully we can start to think outside the box. And I mean, we have been, we have been.
Yeah, and we had Jan Backlund, I think is his last name, but doing V-Notes, we had him come on the show last year. And again, the way he was describing it was like standing on my head a little bit, like doing things backwards. It was, like listening to a record backwards. Like it was all the same steps and all the same anatomy, but you had to think about it sort of differently, but then you get those, this, visual cues and those things. It's just doing it enough times. But the way he described how he sort of like slowly became more advanced and more comfortable in reaching, and then you get into the pelvic sidewall and the retroperitoneum via V nodes going, oh wait, okay, so it's this, I mean, the anatomy is the same, but you're coming around looking at it from the back side and going, it looks different, but I know it's the same. So how do I get my brain to see it differently? And I think you use an articulating camera, but what I like about statistic laparoscopy, and it's not as big a deal now with the XI, it's still a bigger deal, but doing, 2 kilo plus uteruses, putting the camera laterally lets you see what you couldn't see from the midline. It's just, there's just not room.
Yes. If you can do that, if you know the anatomy well enough to do that, there's no more, this uterus is too broad to be able to do a laparoscopic approach, right? Because you can come around. So if you're going to do V notes, think of how well you have to know the anatomy to be able to visualize it from all different directions. And Amy, from a prolapse standpoint too, it's the same. You have to know the structures, no matter how you're coming to the, how you're looking at these structures, whether you're coming through vaginally or laparoscopic or robotic or coming from the side. You have to understand the 3D anatomy of that. So I think as GYN surgery continues to evolve and improve, and our surgeons probably tend to focus and do more, then that's gonna really propel our ability to take on new technologies.
Have you been doing sacral colpopexy through this approach, or is it mostly just the hyst?
I mean, I have, but it is risk reward gain. Sacral colpopexy, if you think about the prolapse patient, just in general, they're at higher risk of hernia, right? So they have weak fascia. So I want to keep all my incisions as small as possible.
Yeah.
So I do those with traditional 4-point.
So can I just ask about this, your curiosity and innovation streak? Because you came out of fellowship a couple years before I did. I finished in 2009. And then I really, just reflecting on innovation in urogynecology, it felt so innovative. It felt low liability. And then the transvaginal mesh just hit, and it was horrible. And the robot and all the things, right? It just got real gnarly and ugly and nasty. And it made, at least for me, but I think it also changed the arc of a lot of people in my generation career of you get called to depositions and all these other things. And it wasn't necessarily our cases, but we got swept up in it. How did you keep your spirit alive, and your, appetite for risk and safety and all of those other things in this challenging environment? Because I think it's gotten more innovative recently again, but after being quenched for a long time. Do you know what I mean? Historically.
Well, so the difference, if I do a single port hysterectomy, it's the same surgery, right? It's actually the same steps. It's the same energy device now. It's the same surgery. It's the same suture. I don't have to close it a different way. It is the same. When we went through everything with the meshes, it wasn't the same. We said, mesh A, colpopexy, tried and true, works great, gold standard. But it's hard. How about mesh B, which is completely different, and the only thing similar was they both had the word mesh in them. So I think that was very different. So I don't do a whole lot now of innovating by changing the procedure, right? It's how can we make our procedures more efficient? I think efficiency is huge. When I was a fellow, my thesis was on risk factors, perioperative risk factors in the elderly. And the one thing that came out, and this was back in the day when we were first doing birches, first doing laparoscopic birches, laparoscopic colpopexies. We did one of the most in the country. I did 12 in my entire fellowship, which is funny. So surgical time was the #1 risk factor for complications. #1. It didn't matter if we opened you, robotic, or laparoscopic. If it took 4 hours, that's where you had a cardiopulmonary problem. And so for 20 years, that has been my thing, is how can I make my OR more efficient? So for me, I'm not switching a multi-port hysterectomy for a longer hysterectomy just so I don't have a, a scar. These are similar times, if not faster, honestly, because I only have one port to close now. So, I think time and efficiency is another focus.
Yeah, I remember your study because it was the IV fluids, and then ARS came along, and we were like, the sine qua non of ARS is IV fluid restriction, which you knew, right, intuitively, because they would get flooded with like 2 liters for EBL of like 25. It was crazy.
Yeah. Oh, they would, and I would have the discussion with the anesthesiologist. Well, wait, how come? Well, the calculations show, and this is what she needed. She's dry because she had a bowel prep, back in the day. Yeah.
Yeah, it's pretty crazy, but I think it's super interesting because your point is so it is about refining and improving our technique and the procedures that we're doing. And I just watched this neuropelviology talk today and doing.
I watched it too.
Yeah, doing the nerve sparing stuff. Because sometimes we would just blaze through.
Yeah, no, you're right.
The super hypogastric plexus, and you just don't recognize it. And then now watching the videos, I'm like, I probably blazed through those like unknowingly.
Back in the day, when I was a fellow, we were just trying to find the sacrum through using this scope, right? The scope technology wasn't good. It wasn't like 4K, and I use all 3D scopes now. So it was very different back in the day.
So are you wearing 3D glasses? You're doing the whole...
Yeah.
Flexible scope with 3D glasses?
So the flexible 3D is actually 10 millimeters. So for single port, I'm using a flexible 5 just for space. So I don't have to make that umbilical incision larger. But everything else I do 3D. If I'm doing robotics, is 3D. If I'm doing conventional laparoscopy, multi-port laparoscopy, I have a 10 millimeter 3. And my vaginal surgery is also 3D.
Very nice. He pointed at his eyes for those who were listening to this. But so I wanted to ask you and Amy both. I think as the one in the room who's only MIGS trained, vaginal surgery was fun in residency, but really we just didn't do a ton. We had a great urogyn division that if it was a good vaginal case, you go send them to Dr. Delancey or Dr. Fenner or somebody across the hall. So we just didn't do a ton. I think I was the fellow representative of the board, and I was at her table with a bunch of these big guys that we all know. And as a new attending, I was kind of feeling bad, like I hadn't done anything vaginally, and asked the table, I said, do you guys do a lot of vaginal surgery? And someone was like, the last vaginal hysterectomy I did was in 2001. It was, something like no one had done it. So our MIGS world, we get so focused on this, talk about perspective, but this top-down approach. How much was your urogyn training sort of a motivator, or at least or helpful to help you sort of see potential and approaches being different? And Amy, I know, what percentage of your practice is vaginal versus laparoscopic for both of you guys? I'm just curious.
I do most of my cases vaginally. I did primary sacral colpopexy for a while, and then the mesh hysteria hit, and I was practicing in DC, and I was like, God, I am like, why am I trying to talk these patients into sacral colpopexy? They clearly do not want this surgery. So then Andy and I actually switched. Andy Sokol and I switched around the same time because we were like, we were doing primary sacral colpopexy, then we were doing vag chest plus sacral colpopexy, and then I just started doing vaginal hysterectomies, vag spatials with uterosacrals, and I was like, this is great. But I will say, to your point, Kevin, about having different perspectives and coming from below and coming from above, it really helps you a lot.
Oh yeah.
Just having a different, I just remember doing urogyn and then also being so much better at perineal repairs during, obstetrics, and just knowing the anatomy so much better, and the spaces from below and from above, and then with the time, like knowing the anatomy, and then and also the other thing that is so great, and I tell the trainees this all the time, is there weren't any videos, there wasn't any surgery there was nothing. And so I almost feel like it's excuses when they're not watching the videos, because I didn't have that. I had to read these like wheel lists and try and piece it together.
Pictures, right? Jeff Cundiff's pictures, hand drawings, right? So
wheel lists almost like online. It was like 2D black and white drawings. They were fantastic. but
Yeah,
I was
but we
on that
didn't
thing all
have
the
like
time.
Jeff Woo's like MIG tips. I mean, his MIG tips videos are fantastic.
Or
you know?
GYN doodles, like illustrating everything in 3D and like, moving. Yeah, it's amazing. But yeah, Surgery U alone. I mean, the number of times I've watched those videos, you watch a video before you get a big case the next day. Okay, this could go this way, that way. You get your algorithm in your head and go, okay, if I see this, if I see that, if I could do this, I don't have access to that. You got to have like all your plans for everything. And so those videos were huge.
I like Instagram as much as the next person, right? Or any of the, scrolling social media. However, if you just get on Surgery U and just kind of scroll through a couple of surgeries, it's the same feeling. Maybe I'm a nerd, but like I still get the same dopamine release, but I feel like I did something, right?
Yeah. No, I mean, I think that's the thing that's super cool is that you can look online, not even just Surgery U, but even YouTube and look for videos and, huge periclitoral cysts. And you're like, okay, I need some pro tips here. Because it's like, the anatomy, you know how to do it, but it's just comforting to watch people reconstruct and then, don't trim too much. Okay, that's great. It's going to shrink, things like that.
Yeah, that's exactly. So I don't know if you know that, but that is a focus of sort of what I'm doing right now a little bit too, is reconstruction. Like, so aesthetic cosmetics and vulvar reconstruction for big abscesses. I don't know why somebody posted something on Reddit and now people will come for vaginal abscesses and Bartholin's cysts and again, using some lasers in there. So this time is so exciting.
Why? Just like learning how to do this or just more technology?
The open communication. It is so easy to do this, right? To talk to you, to go watch whatever you did last week, to talk about any of these things. Like Johnny Yee, when he did his single port for robotics, right? I love that, so it's just great. I've got, you got your list of your podcasts and you're driving to work and you're being productive. You're learning something. I don't know. It's better than listening to the radio.
It is true. It's so much, there's so much more. You don't have to be a learner who is just reading or trying to figure out from 2D drawings. If you're a listener, an audio listener, or my son listens to podcasts. I love that Google, what is that program that you stick a PDF and then
Notebook.
Notebook LM. That thing is amazing. My son loves it.
There isn't, I guess just to kind of bring it back to single port a little bit. I love single port. It's great for my patients. It's not for everyone. I'm not going to say it's better than anyone, but talking about conversation, in 2010 when this was going on, there's a quarterback, Matt Castle, and he was in the playoffs and he got an appendectomy. And so in the world of single port, right, in the multi-specialty, the general surgeons and the gynecologists and the pediatric surgeons, and everyone was exploring this, there was a big discussion about, okay, he's in the playoffs, he's an NFL player. What kind of appendectomy are you going to do? Are you going to do a, McBurney's point, small 2-centimeter incision? Are you going to do 3 5s? Are you going to do 1 15 in the umbilicus? So the end of the story is he played in the playoffs on post-op day 11. So, in terms of our post-op restrictions. So I don't know if it was single. I don't know. The point is that there was a lot of discussion about it. And probably there was a lot of opinions at the time of, I would do single port because it's in the umbilicus versus a lateral, or this, that, and the other. I think he probably had a multi-port 5mm one because it really was pretty cutting edge at the time. But where he was, it showed up on my feed, the discussion.
It's incredible. So when I've done a handful of cases over the years, really what has not been a big part of my practice. But one of the things that I always thought with robotics specifically was that because it's more intuitive and because it's, it was supposed to be the big game changer, I think, for laparoscopy, which I don't know that it was. Certainly it's everywhere, but I think it wasn't the big leveling. The device didn't level the playing field for everyone. You still had to be a good laparoscopic surgeon with robotics.
Oh, absolutely.
And it actually, I always say it's like the space shuttle. Like it's beautiful when it works, but there's a million pieces. And it doesn't take much for it to go sideways. You actually have to,
You have to know the anatomy.
You have to know the anatomy.
giving a Ferrari to a bad driver does not make them a better driver. It makes them a weapon. But in thinking about sort of the complexity, the counterintuitive nature of single port, even more so than traditional laparoscopy, you triangulate, but in traditional laparoscopy, but you're crossing streams in single port, whereas with robotic, if you could get it small enough and make single port effective enough and useful enough, it could be a really powerful tool to really change the game for single port laparoscopy. That was just a thought I had. What do you do single port laparoscopy? Is it always straight stick? Do you feel like there's any role for that? Is that something that you
mean robotics?
Robotics. Yeah.
So I've played around with them. Full disclosure, like I'm usually sort of, if I don't consult for a lot of companies, hardly any. Honestly, I like to have like one or maybe two at a time to keep me interested. And they tend to be robotic companies, specifically around single port. So I'm familiar with technology. I do not have the experience of like Johnny Yee or anybody else who's doing that. My thing is, it's definitely easier, right? It takes away a lot of the thing. Like we developed a sort of a roadmap on how to do single port laparoscopic hysterectomy with AAGL. We put together a big task force and we came up with how to do it, and it's where to put your hands, and that's a whole different lecture. And if you're committed to that, we can teach you how to do it, and it's that we can definitely do it. But you got to have an interest and a reason and a dedication to it. Robotics kind of really shortens that learning curves and probably opens up the door to be able to do other things. However, it comes at the cost of a 25 millimeter incision, which I think when you're comparing it to year fives, that's a big difference. For me, I might at times make a 25 millimeter incision, but that's because I'm morcellating a 2,000 gram uterus or larger. But the robotic single port platform doesn't work for that. So I'm a fan. I love robotics. I love innovation. I think it should be done the way it's being done, right? Johnny's doing this in a responsible way, and I love the way he's doing that. I don't think it should be rolled out to everybody just so that they could say they could do a single port sacrocolpopexy robotically.
Kim Kenton and Maggie Mueller are, I think, 100% of theirs, they said they were doing these days, single port robotics. It said the learning curve was much less steep for them than traditional single ports. That was one group I knew who's doing it, but it's not quite caught on like I thought it would have. I was surprised.
Well, it's expensive. I mean, and it's not, you got to have a urologist who's going to buy it, right? Who's going to convince the hospital to buy it, because it's not FDA approved for us yet. So they can't really justify it. You can't go to the hospital and say, buy me one, because you have to have urology bring it in, or I think maybe ENT also. I think ENT, there's a lot of potential there for that. It's really neat. I really do like it. I'm definitely a fan.
Not there yet. Like not totally done yet.
Not totally. I'd like to see it smaller. I'd like to see it more rigid for the MIGS side of it. Maybe with endo. So the thing about endo is I think it was Roseanne. It was either Ted Lee or Roseanne Coe who told me this. Like with endo, it's like a war, a battle. You have to attack it from the right and then regroup and attack it from the left, and then regroup and attack it from the top and the bottom, and then go back to the right. And with single port, traditional single port, the way I teach it, you have to stop, almost even with an expert surgeon, you have to stop, take the instruments out, and then reset up and put them back in. So if you're having to stop and reset up every 4 minutes, we lose that whole efficiency thing I was talking about. But with the robot, you probably can just kind of continue on and attack it from the right and the left. And I think from there, it's going to give you some advantages.
How were you able to teach this? Like, are your former fellows doing this in their own practices?
They can all do it. So again, that's a whole nother thing. So I don't think that they're going out and doing it. They definitely can leave. When they leave, they can do it. When they leave, they can do a robotic colpopexy in an hour. They can do a laparoscopic straight stick colpopexy in an hour, and they can do a single port hysterectomy, including closing the cuff. So the problem is that when they leave, usually they're in a new place without somebody to help them. And so even though they can do a laparoscopic straight stick colpopexy in an hour, most of them go back and they all do robotics. So it made me just realize that it's good from an experience from an anatomy thing, but our system isn't great yet. The medical, I mean, maybe our CMOs can help with that, but the system, they just don't have, they're coming into a group. They don't even have a tech that they always, a PA or a nurse that they always get, right? They don't even have a dedicated GYN team a lot of times. So with a robot, you can do it yourself. You can assist yourself.
That's the thing about having the skilled assist in conventional laparoscopy is that unless you're in a training program and but it also just depends on your access to robotic time too.
Yes, for sure.
Because that's
a huge problem in Charlotte.
Oh, I'm sure.
Huge.
I mean, everywhere. We're battling with urology and cardiac and all these other service lines. So yeah, and the teams are crucial. How did you train your team up for this? Was it the same?
So it goes back to my efficiency, right? Since I've been here, 15 years ago, it has been preaching. It's not just I need the same team. It's they need to know the names of the instruments that I'm going to ask for, and they need to be right outside the room, not in the basement, not in SPD. So they need to have everything, all the sutures. I always have a suture cart that's got all the sutures that I might need. So they don't have to go run, right? If you ask for something and then you got to wait 3 minutes for them to find it, or maybe they're on lunch and it's somebody new, these are bigger problems, right? And staffing. And
I have conversations with surgeons about this all the time. I mean, a former medical director of the ORs where I am, and now still in my role, but just even as a surgeon in the OR with residents and students, be a pro. You set the tone. You're a leader. You set the tone in the OR. How you treat people matters, and it matters more than just people liking you, because people have to want to come to work with you the next day. Building a team is getting people to want to come back and do hard things with somebody, and they'd much rather do hard things with someone that's fun and that's going to treat them nice and make them feel valued. The work's going to be way harder with someone you don't like. And so, after 10 years now, I've had the same tech almost, when she's in town, when she's at work, she's in my room, and we love each other to death. We're close, but she texts me 6:30, hey, what do we got today? What do you need? She is all in on what we're doing. Our cases go better. And people always go, oh, how come you got her? Because you're the medical director. No. I'm medical director because of her. I'm medical director because I ran an OR that people wanted to be a part of, not the other way around. And I think that's part of what you got to teach is the culture of that room is you. You get to choose it, how you build a team. You can do crazy complex things, taking out a 6-kilo uterus laparoscopically. I wouldn't recommend anyone do that for fun, but you don't do that with travelers who are just showing up for the first time. You don't do the limit of what you're doing, that 1% beyond what you've done with new people. And so I think, you gotta build the team first, then you go do hard things. I think it's really something that maybe new trainees or new grads need to understand is that team that you build, you're building from the first day you walk in the room, please and thank you, timeouts with first names, understanding who people are and let people go. That was a fun day. It was long and we did, it was a hard case, but it was a good day. And then people want to be a part of that. And so that, I think.
So how do you do that? How do you do that when maybe you're a generalist or a new grad, even as a specialist, and you get 1 OR day a month?
So, when I first started, I thought, man, I'm going to come to UK and they're just going to be so excited for me to be here, man. My buddy always wears a T-shirt on his anniversary that just says "You're welcome." They're going to be so happy that I'm here, and we have no REI, so I wouldn't get referrals from REI. Onc was like, we don't need you. What are you talking about? And the generalists wanted to keep their volume, and I got no referrals, none. I built my practice from dirt, so I wasn't operating much. And so the way that I had to build my team, it was hard, but ultimately it was, you got 1 day a month, or you got one case. As you build your practice, those have to be good days, and you have to make people want to come back to work with you. You have to start with that. Connect first, then lead, right? You have to create relationships and and understand who people are and tell them where you're going. My first nursing clinic, it took me a year to even find a nurse who was available to work with me because they all had their pre-existing relationships. And then we have me and Ann have a really good time in clinic. And then other people start going, what are those guys doing over there? That looks a lot more fun than what I'm doing. And all of a sudden you tell them about your vision and here's what we're doing. And it's so exciting. And, that people then start glomming onto you and you start picking up, I joke about this big gray blob. You just sort of just pick up things as you roll along. And if you have a vision and you have, a positive attitude and you have a plan and make people feel valued and, good morning and thank you and what a great day. As you're doing these hard things, it makes people want to be a part of that. And it's slow and it's not like it happens tomorrow. But looking back, I can't imagine my career and all the great things I've been able to do and been fortunate enough to get to do is because of the people who gave me time, who gave me the opportunity. I was medical director of the OR because the nurses said, hey, we like you. Would you do this? We need one over here. Can we go talk to the CMO about making you the medical director? I was like, sure, I would. Okay. I don't know what that means, but yes, because they said, we like how you do things. And it was the other way, right? It's starting with that. It gives you opportunities, not expecting these things to happen the other way around.
I do think it's a team approach, but the other thing that's hard to thread the needle, especially for women, is that but any kind of surgeon, is you want to be competent, really good surgeon, keep your cool, know your stuff, low complications, all the things, but you can't be somebody who gets walked on, and also acknowledging that we do have a team approach with nursing, with SPD, with the front desk, with scheduling, but you have to know who the levers of power are everywhere. And it may be somebody who doesn't have the title, but they hold the power. They hold the schedule power or whatever it is. And, sometimes it's informal power networks and trying to figure that out. I mean, Kevin, you've been in a couple of places. How did you figure it out?
Well, I'm impressed with kind of Mark's approach here, and that's, I haven't actually put it into words before, but he's right on. You've got to be, I joke with my staff and I say I'm high maintenance, but I'm nice and respectful. And there is something about the person standing across the table or across the room from you that you can find respect for. And so you just have to really believe that and actually respect them for what they're doing and think outside of it. And they will be invested in the success. They're already invested in the patient's success, but a lot of times some of them are coming at it, because they have to protect the patient from some arrogant surgeon. And instead of work together as part of the team forever, come in on their day off so that they will operate with you because they know that you're going to do good work.
It feels like your collective work, right?
Yeah.
I don't think of anything that we're doing in the OR as my work. They create a space to allow me to have that success. And I mean it. This is not like some, bullshit talk. This is like, I guess, or baloney talk. I don't know if we're editing this, but it's, this is genuinely where I come from. I feel truly grateful that people are willing to spend time with me. Maybe it's the kid who wasn't picked for the middle school sports team. So whenever anyone is willing to work with me, it's like, what can I do to keep this thing going? I'm just so grateful for it. It doesn't mean, and you said this, it doesn't mean having lower standards. Excellence, right? We are going for perfection every day. We may not get there, but we'll hit great along the way. But it is saying this is what we're going to do, and then doing the hardest things. I've had attendings who were as nice as could be, but my goodness, they had the highest standards, and there was no 95%. We're doing this, and I've had others who will bully their way into greatness, but that gives you about a week before people just say, I'm out of here. I ain't doing this. And I've tried to have these conversations with surgeons in my hospital and say, listen, you got to create a place people want to come back to, because they complain about the travelers and they complain about, there's a nursing shortage. We cannot pay everybody more to come work with you. So if you're complaining that you don't get the nurse every day that you want, how about you treat them nice enough that they want to come back and work with you? And they're just like, what are you talking about? It's like, it's that's what you get though. You yell at people because you want greatness. Okay, you'll get it that day. You're not getting it tomorrow because they're not coming back. And so it's a long game. That's the end. That's the biggest thing. It is a marathon. It's a long game. You got to build relationships that truly matter, or you're going to have fleeting success, and that'll follow you around.
You have a hard job. You have an important job, because I think what's going to happen over the next several years, sure, there's going to be lots of innovations, right? We're going to train people. We're going to focus our practice. We're going to get better surgically and skill wise. But the other side of medicine, the staffing side of it, the keeping people happy, the keeping the patients happy, that they have a good experience and wellness in general for patients, team members, surgeon, everybody, like that's what's going to be important. And over the next 5 years,
that's it for me. That's all we have.
Yeah.
If we don't create a place to work, I've heard it again and again, I can get treated like, for more money somewhere else. If we don't create a culture that people want to be a part of, we have the sickest patients in the country. We have more transfers. We got a sick population of patients. If we don't make this a place people want to come, what are we talking about? You can't run a hospital without staff, without people. And luckily I have a boss who is all in, who's bought in, who's like, yes, that's what we're doing. That's your thing. This is how we're going to approach it. No tolerance for nonsense. Act out and be unprofessional. You're going to be mean to people, punch down. We'll call you out. And we'll do it in a way that is, by the book, and there's no exceptions. And just because you think you're a high volume or a powerful person, no. The no asshole rule is a book I live and die by, but it'll always cost you more in the end to keep them around, because the behavior you tolerate is the behavior you promote, period. You're saying this is what we want from everybody, because the squeaky wheel gets the grease. So we're trying to change culture. It is a slow moving, slow turning ship, but I believe that's how you build a culture in a clinic. That's how you build success in an OR. I think that's how you build success and do hard, innovative things like you're doing. I mean, this. You can't do what you did without getting people to buy in, to trust you, to share your vision, to do it with you. And so this, right? And this is what you've done for decades now. It's impressive, and you've done what I couldn't do, which is really be an innovator and just put yourself out there and do things that no one else could do. And so my job is to find people like you and give them the opportunities to succeed. And I think it's fantastic. I've always looked at what you've done and I've always been so impressed.
The other thing that strikes me about your story, Kevin, is, listening to Ted Lee's AEGL presidential talk. For our listeners who didn't listen to his talk, he was like, I write these evaluations for the residents and I say, this person has great hands. Nobody told me I had great hands. He's like, I practice on my box. I had a little box and I practiced and I practiced and I practiced. And I got good at it. He was essentially like saying he's not a natural, but he practiced and he got really good. And you talked about that, getting a box, being struck with the technology and really practicing and being good at it and like visualizing it and really knowing the anatomy. And that's like the fundamental of it all, right?
Oh, for sure. For sure. And the other thing now that they can do that we can't do, and my fellows are actually really good at this, is they videotape their surgeries and then they go watch them.
Game tape.
Yeah, game tape. You get to watch the film and and I say, watch them. Don't watch it the next day. Watch it like a week from now, because you've forgotten. And then, and by the way, just back to that efficiency, I used to do that when you realize that you're sitting there for 4 minutes, like what's going on? It's dead air. And it's because, oh yeah, that's where so-and-so had to go get such and such, and they didn't know what it was, and they brought something back that wasn't the right thing, so they had to go get a different thing. So you start learning that. And then of course, the surgical technique, like, man, if I were just like, why didn't I just cut right there?
Watching yourself operate, or watching myself, I won't speak for you, is one of the most frustrating things I could possibly do. It's like, just do it, just cut it. It's obviously the thing. Just, like, what are you poking around for? I'm like screaming at myself, it's like, I frustrate myself more than anybody on the planet.
You learned so much by watching film.
You know what? I think that is another thing that really strikes me and separates the good from the great. Like, you can be the most talented person, but if you don't analyze these things, how you can get better all the time, you're never going to get better, So you just always have to be like, okay, I could have done better. Mark Walters, even up to the end, he was always like, how can I do better? How can I just get better. And all the
The
great
end of
surgeons.
his clinical practice, just to be clear.
Well, end of his for clinical practice, yes.
No, there was
Yes.
a study. They asked surgical techs and nurses like who the best surgeons were. Then they asked the surgeons who the best surgeons were. And the surgeons that said they were the best, the folks in that were like, they're okay, like below average. And the ones who thought they were like just above average, the staff were like, no, they're the best. Like, because you have to have that humility to think I can be better every single day. There's always more I can do. And if you think you're great in this really complex, impossible to perfect world of what we do, it's not going to end well.
When you start feeling that humble, that's when you get the complications.
That's right.
Yeah, that'll humble you for sure.
Yeah. Well, man, I feel like we could talk to Kevin forever. We have to let him get back to his life. He's a busy guy. And I just want to say thank you. What a pleasure it was to get to chat with you. It's always the good ones when you like look at the clock and you're like, oh man, we gotta end this thing. We could bring him back another day. But that was super fun. It's such a pleasure to have you on. And I look forward to seeing you next time we get to hang out.
I love this. I love it. And I hope to be back on. We can talk about something else.
We'll do it. Perfect.
Thank you for doing such great work, both of you, actually.
No, thanks so much. It was a pleasure.
Thanks,
Good to see
Kevin.
you. Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
And Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Urogynecology.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.